Dr. Popplewell is a graduate of the University of Louisville School of Medicine, go Cards. And she did a residency in internal medicine at Temple University in Philadelphia, and a fellowship in medical oncology and hematology at Memorial Sloan Kettering in New York, and her fellowship in bone marrow transplantation at the City of Hope Hospital in Duarte, California. She's currently the medical director of hematology and blood and marrow transplant at the City of Hope Cancer Center down here in Atlanta. And she's also an associate professor in the Department of Hematology and Hematopoietic Cell Transplantation at the City of Hope in Duarte and down here in Atlanta. You do a lot of traveling. But I want to just mention one thing. Dr. Popplewell was asked about taking care of patients, specifically about lymphoma, but I think her answer was germane to taking care of patients with cancer. And her response to me was very interesting, especially coming from a physician. Because she said, patients are never isolated. The family and the friends are involved, and that is important. Kind of like what we heard the other day. That is important because everybody needs help getting through a serious illness. Everybody needs help. And I think that kind of speaks to the quality of the folks we have here today. So I give you Dr. Leslie Popplewell. Thank you very much, ma'am.
Okay. Oh, thank you. All right. Well, good morning, everybody. Thank you so much for your attention. I appreciate that. Thank you, Dr. Blue. That was a wonderful rundown of CAR T-cell therapy, and absolutely, it's been my privilege over the last 20 so years to help introduce patients to new kinds of treatments that weren't available when I started my education. So clinical trials are the way that we bring new treatments to patients and their families. So I think I've got a few clinical, a few slides. These are not them.
Push it down to advance.
Oh, okay. I'm going down to advance. Okay, all right, it's like TikTok. So I have a lot of slides. I'm not gonna adhere to this very much. I just wanna make sure that they guide me a little bit. So clinical trials are the way that we bring new treatments to patients. Clinical trials are available at a number of sites. A lot of them are academic medical centers, but increasingly there are clinical trials that are expanding into the community as well. And our job is to work with the patients as well as their primary oncologists who often will refer patients to us. We're trying to answer important scientific questions. Our goal is to take treatments that started as a concept in the lab and to take them out to patients in the community. And we do that in a stepwise fashion. And so typically when a new cancer drug becomes available, we start treating patients who have run out of some of the normal options that they have. So patients who have maybe gone through a few different lines of chemotherapy or other treatments, they don't have a lot of other options, they may come and look for a new kind of therapy, a new concept. As we get more comfortable and learn more about those treatments, we start saying, wow, this is really a great treatment. Let's take this a little bit sooner. Let's not restrict it to patients who have had a lot of lines of therapy. Maybe it'll work even better if we start treatment early on. And so the treatments like CAR T cells that started out only for patients who have run out of other options are now available in a second line setting for patients with multiple myeloma. So you have one line of therapy, maybe you have a relapse after that. They really needed to do more research. And so it's true even today that the majority, more than half of children affected with cancer in the United States are treated as part of clinical trials. And that's why the survival rate for children afflicted with cancer has really skyrocketed. We've really gotten much, much better at treating children with cancer. And that's becoming more the case as well with adults with cancer. But we still think we have a long way to go in terms of introducing adults to clinical trials. So as far as clinical trials go, we have a variety. We have treatment trials, and those are the ones that I participate in most often. Prevention trials, how do we prevent cancer from starting? That's an answer we would love to have. We don't have the answer yet, but there are a lot of interventions that are being tried for patients who are at high risk for cancer to try and intervene early and prevent that from happening. We have early detection trials, screening trials. So now we have screening for lung cancer for patients who are at high risk. We have diagnostic trials, and we have quality of life studies as well. So we talked a little bit about the different phases of trials. Phase 1 trials are where we really have a brand new treatment. We've identified a problem, we've identified a mechanism, we're having some good success in the lab, but now we need to try and bring that to patients. And so phase 1 trials are the earliest trials where patients are really getting a new treatment. So with phase 1 trials, we usually will do a stepwise treatment. So we'll treat patients with a very low dose of the new drug. The next group of patients will get a higher dose of the drug, and so on until we're at a dose that we think is both well tolerated and where we're starting to get some response signals. So phase 1 trials are things that people have varying degrees of comfort with. We're learning a lot about the drug. We don't always know exactly how people will respond. Usually there have been animal studies where we get some signals, but people are not mice, right? And we know that. After a phase 1 trial, we go to phase 2 trials. Phase 2 trials are where we've been through a phase 1. We've already identified that there are some good response signals going on. We think it's going to be a successful drug. We think it's going to help a lot of people. What we say is with that, let's take a whole group of people, let's give all of them the same good dose of the drug that seemed to be working in phase 1, and let's give all of the patients the same drug, the same schedule, and let's see how they do. And after that, now we've got an idea. Now we say, this percentage of patients is going to respond to this treatment. After phase 2, then we go on to phase 3, and now we say, well, we've got this new treatment, we know how well it works, we know it works in a lot of people. Does it work better than what we have already? Let's compare this to another treatment that we were already using pretty heavily. And so phase 3 trials are where you're getting an option. You can be getting the new treatment, or you might get the treatment that we already know and are comfortable with, and we know how it works. So when you are talking about a clinical trial with your consultant, with your clinical trial specialist, you want to ask questions like that. Well, what is this new drug? How is it different from the drugs that are available to me in my primary oncologist's office? What phase of the trial is this? How many people are going to be on this trial? How many cycles of this am I going to receive? How am I going to feel? So the risks and the benefits are important to discuss. A lot of trials that I'm going to talk about include randomization. So especially those phase 3 trials where you have 2 different treatments that are being compared to one another. A lot of times we don't let the doctor pick what you get, and we don't let the patient pick what they get. It's a randomized trial. And so when you're going into it, you know that you might get treatment A or treatment B. If you have a randomized trial, it's important to ask, is there a crossover portion to this trial? If I'm getting treatment A and it's not working for me, can I switch to treatment B? And a lot of randomized clinical trials have a crossover option for that. So that's important to know about. When we randomize patients to trials, we've got, let's say we have 100 people, we're going to randomize them into 2 groups. We want to make sure, we don't want all older people in one group, all younger people in another. We don't want all men in one group and a lot of women in the other. We want a good cross-section of people. So it's important to know about how people respond. Randomization is important because it helps us understand how different kinds of people will respond to treatment. So clinical trials, we talked a little bit about phase 1, 2, and 3. I will say, so people ask a lot when they come in and we start talking about trials, am I going to get a real drug, or am I going to get like a sugar pill, or am I going to get something that's not effective? Very few clinical trials these days for cancer include things like placebos. Some of those will include some of those prevention trials like I talked about. But if there is a placebo involved in a clinical trial, the researcher is obligated to discuss that with you. You need to understand if you're going to be randomized, what's the chance that I'm going to get treatment A or treatment B? Is it a 2-to-1 randomization? Is it a 1-to-1 randomization? So it's important to know about that. Cancer prevention trials, as I mentioned, those often involve things like dietary changes, supplement additions like minerals or vitamins. It might include dietary changes. It might include levels of physical activity. So those are the kind of cancer prevention trials that we're seeing a lot of these days. And then chemo prevention trials. There are some chemotherapy drugs that are so effective for cancer patients, and they're so well tolerated that sometimes we are using those drugs to try to prevent a cancer from happening in a patient who has a very high risk of getting that cancer. Clinical trial protocols. So, what happens if you talk about a clinical trial? It sounds like a good option. How do things work behind the scenes? So, if you're a cancer research doctor, like Dr. Blue, you have a clinical trial protocol. And so when you're given your consent form to read over and make a decision, those have gotten pretty long, right? Because there are a lot of ins and outs to cancer trials. So your consent form that you read might be 20 pages long. The clinical trial that talks about how we have to act when we take care of patients is probably about 100, 150 pages long, and they're getting longer and longer. And it governs everything about how we conduct the trial. What kind of patient is eligible for the trial? How is the treatment given? What's the schedule? How do we deal with toxicities or adverse events when those occur? So those are all very carefully spelled out. There are groups of committees that will take a look at us and make sure that we're doing all the things that we said we were going to do when we started the clinical trial. They're saying, are we following the treatment plan? Benefits of participation for clinical trials include getting access to more new advanced treatments. It also includes maybe being part of a trial where you are more carefully monitored. I will say that patients who are on clinical trials usually get more scans, more lab draws. They have a little bit more visits to the doctor. So I tell people it may be a little bit more of a time obligation for you, but if you're getting a new treatment that might be more effective, that may make it more worthwhile for you. So you have to make that decision for yourself, and it's the job of the person who's conducting the trial to answer all of your questions to make sure that you're making the best decision for yourself. Risks of participation, well, some of these are newer drugs. So when I started giving CAR T cells, they weren't yet FDA approved. And it was a little bit of an adventure. We take care of CAR T cell patients differently now than we used to because the toxicities that are associated with CAR T cells are different than the toxicities for chemotherapy, right? And so there are fevers, when the